that we photographed during the last visit. And if you look at this picture, it tells some story, but I'll come back to that story in a moment. Okay. If you look at this picture and you go back to look at this one, you may see something. I would want you to take just 10 seconds to write down anything that you think that makes a difference to you. Can anybody spot something here? You want to try? Shoes. You realize that this picture was taken 10 years ago, 10, 11 years ago when I first went to that community. And that's my little car parked there, and I met these boys. And all of them were not in shoes. Then the stick that they're holding, in fact, is their toy, or is what they're using to play. It's like their car that they're using to entertain themselves in the community. Now, when we went the last year, this was what I found. Almost every child is wearing a sandal. And the other child there is playing with a real toy. And it just struck me that probably there's some very detailed developmental changes going on in this community, but we probably maybe not looking at that in terms of childhood development and childhood activity within this community. In this presentation, what I'm going to do is try to give you some bit of the background of what we have done, what the country looks like, how we have impacted on the communities, and what are the things that with our collaboration we potentially can achieve. This is Ghana. Most of us who've been to Ghana would see, but then Kumasi is like in the middle portion of the country. And the area that we're doing this public health initiative, it's also in the Ashanti region where we have Kumasi, the second city based. The population of Ghana is about 24 million with this age structure. We have about nearly about 40% of the population children less than 14. So it's a developing country population pyramid that you see with very more people at the base, whilst we have the older people very few in this population structure. And these are the communities that we are working. It's about a 20,000 population community, about 18 of them that based on our effort with the collaboration, we have been able to do census in all these communities and have demographic information of all the households that we operate in these communities. And in terms of distance from the city, it takes us about an hour to get to the city. And you would suddenly see a demographic change from city, peri-urban to a very rural communities where even road access becomes a problem. This picture was taken 10 years ago. This field now has green grass. Now, in terms of the community-based participatory research that we do, we have partnerships that are in academic level, University of Utah, the University of Science and Technology, the health institution. The community is also our partners, and we both help to diagnose problems within the community, and we define the issues. We document and evaluate our partnership with these institutions, and so on a regular basis we have meetings with them, and we give feedbacks, and we disseminate most of our research findings. And our dissemination process has also evolved, for which I'll show you some of the things that we're currently doing. When we first went into the community, we asked them about what are some of the health issues that they perceive that we should be looking at. So in their opinion, they were worried about schistosomiasis, malaria, public place of convenience, education for the children, and road network. Obviously, the last one, the road network, it's more of a big infrastructure demand for us to go in. but for schistosomiasis, for malaria, for public health, for convenience, and also for education, we have been able to make some impact there. What have we done? We have done studies into schistosomiasis and have responded to, right? We have done studies into malaria, we have responded. We have done studies into place of convenience, and we have done that. Then we also look at, from our perspective, sure. Schistosomiasis is a parasitic infection that caused by certain nematodes, and that once you get it, there is the urinary type and there's the intestinal type. The urinary type will lead to passing urine and bloody urine as a terminal hematuria. And if you have this condition for a long period of time, you are at risk of bladder cancer. And those with that, it can also give anemia in children and would have their impact on learning process. So it's a very important disease that need to be studied in such communities. So we actually found out that there's a need to also look at some of the things that would be of relevance to us, and some included family planning, because you see those children there are more of those children, and so we realize that family planning also is an important problem. Childhood nutrition and other diseases, which I'll talk about. Cardiovascular disease, which Stephen mentioned. We've done 2 cardiovascular disease studies in this community. Our first findings revealed 44%, and so we said, no, wow, why don't we revalidate these findings? And we went in and we found about 50% of the community, of the population with hypertension. Housing and healthcare facilities were all issues that we had to discuss with them. Now, this picture shows our project vehicle trying to assess one of the communities there. And we needed to cross this river to get there. And when you get to there, you see a whole community living beyond this area with hypertension, with malaria, with schistosomiasis, with all these public health informations. And we needed to let them know what the problem they have. They don't know what they have. And so we, going into that community deeper, was able to identify some important public health problems. Their households, for which we're still in discussions with our civil engineering department in K University, to look at how best, if let me just stop here. This level is the actual concrete level of the house, and so this was all part underground. But yearly erosion has actually eroded up to this level. Sometimes in some of the communities, if I walk with this foundation level at my height. And this one is like almost getting off, so this is like a supporting pillar. Now, what is the health implication of this? Is that shelter for family is being lost. And once you lose shelter, then you're losing a lot of, or you at risk of a lot of public health problems. And therefore, we also looking at how best to address this. This is coming from Megan. Has community as a unit, but as I entered the school, I saw community as a patient. So I changed my last but one slide to community as a patient. And what is it? You have to build strength and resources. We have the human capacity with our collaboration to go into this population and help them identify their health problems and also educate them. We're making sure that whatever they tell us, we put it into action. There's learning going on between faculty, that is at faculty level, as well as learning going on when students from University of Utah and students from K University mix, and which I think Stephen mentioned. We have some mutual benefits that we're getting from the district that is supporting us in making this initiative, as well as we also educating our students at that level. We sometimes look at how best we can sustain it. What has been the history? The history had been that University of Utah students plus faculty plus our faculty were going to the field, and we were hiring translators to be able to translate for University of Utah students to be able to do their field work. But at one point in time when the faculty started, we said, why don't we bring second year, third year, fourth year medical students from the University of Science and Technology who would also benefit from the same program to be part of this exchange. And therefore, it has worked to perfection, where our students are knocking on our doors for every year to be part of this program. And I believe that the University of Future students will also come, learn from our students, and our students also learn from them. So it's been very useful partnership that we have been engaged on. The BCCDP, what is it? It is a collaboration between the University of Utah, Kwame University of Science and Technology School of Medical Sciences, the Confederate Teaching Hospital, the district, as well as the community that we operate all together. And we try to do that to improve education, infrastructure, water, and sanitation. And I'll be talking about water, I'll be talking about sanitation, and I'll be talking about agric as well. It's a continuous knowledge exchange across partners. I think I've mentioned that. And also we do that with evidence-based interventions, and I'll talk about that, and I'll provide some students with different, when we look into our students' background, we have students from agriculture, students from civil engineering, from tech joining this industry, and we have students from health economics also joining, for which some of them have done some work on the agriculture program that we're currently engaging on with Brian and his group. Now, this slide is showing community diagnosis. What are some of the issues here? Census, physical examination, malaria prevalence, water and sanitation, GPS in trying to know positions of each household and the type of diseases that they come out with. The childhood mortality study, another striking one, the helmet study, the childhood poisoning study, intervention, hypertension 1, hypertension 2, and then the immunization study. Currently doing some major maternal intervention where we're looking at maternal micronutrient supplementation and following up mothers for a longitudinal period of time to see some impact in terms of behavioral change. And so the last one is currently ongoing. The community is the community that would want, you could see that need care or would want health access. And so if they are not able to access the tertiary institutions where we have the mammogram, we have the MRI, when we drop in with our car and we do the basic examination on them, they are pretty happy, and they come in and they will queue wherever. So this is one of the school blocks that we have converted it into our clinic. Thank you. And in one of the studies that we were diagnosing malaria and enlarged liver, enlarged brain, which is a sign of chronic malaria, we have opportunity to do ultrasound at the field level, where medical students from University of Utah and our students join hands in looking for splenomegaly and hepatomegaly as a sign of repeated malaria infections in the population. And this one was also a very important exchange program. Now we have the community also coming in, and this is the malaria rapid diagnosis test program where we find children who have malaria parasites. It is interesting that you can go into some of the endemic areas in Ghana where a child sitting in the classroom had about 2 or 3 parasites of malaria parasites with no symptoms, called asymptomatic malaria. What is it? Do you live it? There are several theories coming up. Do you live it or do you treat that child? The problem is that if you allow that child to go with the malaria in an asymptomatic state, it means that every parasitized red cell would be destroyed. So the child would gradually become anemic in class. And being anemic in class means that you are unable to concentrate, your cognitive functions and all other things will be impaired. And so chronic anemia within a population has effect on cognitive function because it will lead to anemia. And so we did also a similar anemia study, and I'll show you some of the results. And so this also our Ghanaian counterparts doing the abdominal palpation. They will do the abdominal palpation before they go to our Utah counterparts to do the ultrasound together. And yeah, we have them queuing up and very happy to be with the children. And so we feel that if they would want to come, then we should also go with the health information that would help them to avoid diseases. In the physical exam program that we did, 399 children were examined. The prevalence of splenomegaly was 33%. Hepatomegaly was 23%. Pallor, that is just physical examination of the conjunctiva to estimate whether the child is pale. We had 26% of them having pallor and 5% having fever. And we felt that the levels of splenomegaly was very high, and the locations of the household did not show any correlation with this information. The gender distribution were almost the same. The mean age was around 29 months, that is 2 years, 2.5 years, thereabout, of children that we're looking at. Now, we did not do it just for one community. We have community A, B, and C, and the findings were like consistent. We have those without malaria, those with falciparum alone, and those with a mixed picture coming in, and we have the hepatosplenomegaly showing up. So in some of the indicators of endemicity of malaria, hepatosplenomegaly, it's used, as well as doing microscopy to look at the count and the densities within the children. And this also is showing the densities within those that the RDT, that is the rapid diagnostic test kit, did not pick malaria parasite, but then when we did microscopy, we were able to pick parasite, and you realize that the parasite density varies from somewhere around 0 to around 12,000 per high power field counts. Again, when you go in and you find it, especially those with fever, you have to treat. So we go in with medicines and treat. Sometimes we also go in with referrals, such that some of them needed to be referred to the tertiary institutions. They are referred immediately to the tertiary institutions for care. So, high malaria prevalence, few interventions, chronic anemia in children, a public health problem. How do we address that? Health education, bed nets. Luckily, the World Malaria Program has distributed bed nets to most sub-Saharan African countries, and Ghana benefited, and so we have widespread distribution of bed nets to this population. So we believe that the spleen rate level, the liver level, as well as the parasite density level should be coming down, and that we believe that in our next studies, we should be considering a repeat of such study to look at the endemicity of the disease now. Water and sanitation and schistosomiasis. This community for the past 50 years have been using this stream to wash, to bath. If children go in as a swimming pool to swim, and so you have a child who can swim, but then this is where they get the schistosomiasis from. There are some snails that the parasite would have to go through and release some cicaria, and they would pass through your skin when you bath through this river. And so we needed to do this study. We found every child, every community person who had schistosomiasis was treated. And doing that, you would immediately reduce the level of transmission within the population. There are other programs where you can target the snails and eradicate the snails from this community. The other sources of water was not very good in this community, so we help in also helping them to cover this well, as well as making other own. Currently, the community that has this problem has pipe-borne water, and therefore water is not a problem there. But then we needed to also do one thing after we had done a stool study to realize that the children in school have hookworm in their stools, and therefore we needed a hand washing program where students from UTA, students from K University go into schools and teach them how to wash hands. So this is one of the hand washing practices going on in some of the schools in the community. And here it's still ongoing. That one was a higher class, and this one is a junior class that is being done with a training program. And here I think the picture is much clearer, and you can see. So you find a problem, and then you respond to that. Apart from the hand washing, there was the need to also provide a sanitation area for the students, such that for the people, so that when they go to school, then they would have a very good place to have. So the study went on further. Apart from the academic knowledge that was built between the academic institutions, where posters were made by students from in their global health conferences, we also had to go in and do this another drinking water quality sources program that was also presented in the global health conference. And then we needed to also provide them with a sanitation facility where we have a 6-seater water closet facility with water flowing from underground pump that we provide to them, such that this is very close to the school, and the school children use it as well as the community. And here where we found hookworm and other intestinal herpes as a problem. And this has been built and is in operation within the communities. So that is one of the public health interventions, in addition to the hand washing, that we had to engage on. Then another question came out, how are they assessing health? And children dying at home. And so they need to do the home mortality study to interact with mothers who have lost children and say, if somehow you've lost your child, where was it? Was it in a hospital or was it at home? To be able to understand that burden of problem there. And what was it? So our primary objective was to determine the frequency of death for children under the age of 5 in the sub-district that we're currently working in. And we also try to understand some of the symptoms that led to death. So we had collected information in this population using what we call the verbal autopsy technique, because some of the deaths had occurred already. So using the verbal autopsy techniques, you were able to get an approximate cause of death in this particular population. There were 9 communities that were used, and our fellow that were involved are the ones at the back who supported us. Now, if you look at this picture, you would see a mother at the back with a black cloth. That mother is a potential, or was a potential, bereaved mother who had lost a child, who was part in the verbal autopsy. And in our culture, when you lose your child within the first 2 weeks, you put on black as a sign to attract sympathy from others. And so she was at that day, even though had a lot of children also to entertain. What was the findings? 118 cases were identified. 92 households were involved with these cases. And in each household, with more than 1 death were 23. The number of neonatal deaths were 28, and the number of post-neonatal deaths were 90. And these are based on the partnership in terms of academic learning, and we have students from K University, we have students from Utah joining us on the field to do this. There's community interaction, there's international academic collaboration, and also students are exposed. I can tell you that not only the University of Utah students have this exposure, but some of our students are coming from the cities and so have not even seen such rural communities before. So it's also an eye-opener to them as they join us to the field. So our students are also benefiting from this. The average age of a mother was 36 years, and the medical care sought, that is those as a result of an acute illness in the child, 62% went to the hospital and the rest did not go. 53% of the deaths occurred at home, and the health records were kept for only 20. Based on this information, then we needed to respond. So as part of the study, we realized that access was a problem. And so what did we do? We initially also published this information in the international journal. The lead author was Steve Manotti, and these conditions, pneumonia and malaria, were the leading cause, postnatal and asphyxia, as well as neonatal sepsis, were the causes of death based on the autopsy, verbal autopsy study. We needed to respond, and what have we started doing now? We realized that the deaths were in areas where access to health was a problem. And so with the initiative of the UNU and some funding groups, and we have been able to provide 3 CHIP compounds. CHIP compounds are called the Community Health Planning Services compounds. These are like clinics where a health worker is there for the health worker to do an initial assessment of the child's condition and say, based on the findings, he should move on to the next level or should start some bit of a treatment. And these facilities are now in existence in different geographic areas of the program. And we had to move full speed to provide this because of the findings or the revelations from the child mortality study. Otherwise, we thought, okay, they need a health post, but they are not even going to the clinics because they don't have access. So the current BCCB, we have the Study Abroad program where we have the students from Utah, faculty from Utah, students from K University, faculty from K join, and health information we disseminate. Dissemination is becoming a key part of our program. Water and sanitation, I've talked about that. Economic to agriculture program. We realize that if we are able to engage the youth in a very good agricultural program, then they can also get some bit of resources to be able to take care of their families. And so the agricultural program is running where we have a citrus plantation which has been supported by academics from here and also from Ghana to help them grow. We almost getting there in getting some products out of this citrus plantation as part of the agricultural component to improve on economic power of the citizens in one of the communities. Providing health facilities, that's the chief compound, and also doing the micronutrients for women in that reproductive age. And Stephen mentioned it, we have the students interacting at several levels, understanding the protocols, understanding the field challenges before they go in. And there's an orientation program, and they do also feel that we come back, give feedbacks, and this is a typical picture showing students working together on the field. There's also an orientation there where they meet and discuss and share ideas. Both cultural differences are also shared, and experiences are shared during this interaction among students. So I think this is one of the immunization groups during last year's program, trying to understand it. Now, as part of the dissemination program or the health education program has evolved. We used to go in the evening with our generator, with our microphones, and try to get them in a very small classroom, and then our generator is making a lot of noise at the background, and our health information officer is also trying to shout to the mothers to hear us that these are the problems that we found, these are some of the alternatives. But then we realized that based on our evaluation, that was not being helpful. So there has been a modification of that. And what have we done? We orient students, we train students. We're going to do much better next year in terms of how to even prepare them to have the skill to counsel, the skill to transfer appropriate health information to these communities. And we have also, let me move on to one other slide. I can't find that slide now. But then we have gotten them now moving into household in pairs. So one University of Utah student, one Ghanaian student understand the public health implication of what they're going to say. They go into the household, sit down with the parents and the caregivers and try to educate them. And that is what we currently am engaging on. And we're going to improve on it next year, where we're going to evaluate the message that they give to the community members as well. This is not occurring in majority of the communities in Ghana, where people within the rural communities who cannot read any flyer or whatever it is, and would only listen to probably music on an FM station, and would not sit down and listen to something about hypertension or everything. But now you having him cooking but sitting on the side and discussing hypertension, childhood mortality, water, sanitation, hand washing. And we believe that this type of initiative is the way to go at the moment to be able to bring health to the rural community. In one of the training exercises for the census and geographic position mapping, we have students from University of Utah and K University trying to understand how the GPS machine works. And that was the first time some of the students were even holding a GPS machine and trying to understand how a GPS machine is using technology to guide you to your home. And this is also two students in some interactions at one of the households. This slide is showing the micronutrient supplementation study, where mothers are coming in to be educated on the need to take fruits as well as vegetables, as well as take micronutrients pre-conception, so that they are healthy and their newborns are healthy. And it was initiated in Ghana last year and is currently ongoing. Now, the big one that worries us, that scares us, is this. And when you go to the World Health Organization homepage on non-communicable disease, you would have these figures there. There are 36 million of the 57 million global deaths in 2000 were due to non-communicable disease. And 80% of the premature heart disease strokes were due to that. And when we go into our community, we find that 40% to 50% of our population have hypertension. And nobody is reaching them to tell them. Stephen will tell you that when you went there, they, of course, you know, hypertension would not give you any sign, and they are just in the community, and therefore we need to respond. So with our first study, we needed to do a second one, and now we think we have enough information to go and make strong advocacy. But when we're going for the second one, we needed to also infuse with some public health intervention. And therefore, our students were equipped with some messages to be able to educate them. All the 44% who were found to be hypertensive were given referrals immediately to go. But then if your health education is not strong, the individual may not go. And the next time you see the person, you see the person heart failure or stroke. And therefore, in part of the meeting that we held here and came for was to look at ways to make sure that we are on top of the situation. And that's the publication that is coming out from the first one. And the conclusion that I would want to read. The high burden of hypertension in this population, along with considerable less detection, treatment and control, is of great concern. There's a need to promote health education, measure that would foster prevention and early detection of hypertension. And so we still believe that even the cheap compounds that we have provided in different geographic areas, our health education should be such that individuals within the rural community can go there and say, check my pressure at least twice in a year to know how you are doing. And therefore, apart from working on mortality in children, these facilities are also going to help also work on these non-communicable diseases. And I think he showed a similar picture of the training before the hypertension study, and they having students having discussions before the community outfits. Yes, this is the picture that I want to show. So what we did was, in terms of the health education, we mounted our posters in the community walls. Then the students are put into two. Then they are north, south, east, and west. And they go into home by home, as well as two residents around the community center, where if a community member wants to walk into that poster, then they would also educate that person at that level. This is not happening in any part of Ghana. And we believe that it is the way to go. We have medical students, second year, third year, fourth year, every summer in Ghana, going home and all that they will probably be doing it, tweeting and sending Skype messages. And for these 3 weeks of their exposure, they make impact to the community. They learn, and also they go back and they understand what their tutors tell them, because they've seen the reality on the field. And so the last one down there, you see two of the students, Utah and Ghana, moving into one community and interacting with the household. We at this meeting that I came in, decided that the students would even evaluate themselves as they go into the household, as well as evaluate the information that they've given to the women and say whether we are even making an impact. Because you may go in and say hi, and no impact. And so we're going to do that in our next 2014 program, and we probably will report on that. So some of the flyers that they go in, they try to say who we are, what we do, to be able to give relevance as well as credibility to the information that we take to them. And we've done studies on poisoning. At the tertiary hospital where I work as a pediatrician, we've seen on the average about 1 to 2 cases of poisoning a week, of all types of, you can imagine everything. The most interesting one is a mother giving kerosene to a 2-day-old newborn. You cannot imagine that. But what happened? Lights went out. This mother gives water. Water is in either the Voltic or the Dasani container, as well as kerosene is also in the Voltic or a Dasani container. The child is crying, no lights. So the mother just lifted this bottle of water, and before she could realize she's giving the child kerosene. And so we decided that let's also go into the communities and look at where they are keeping all these agents. and all that thing. So we've done also a study into home poisonings, and we have done a bit of dissemination as well as health education on that. We have this also leaflet for hypertension as well as childhood immunization, which we used last year, and we're probably going to modify it for next year as well. So our future activities is linking the BCCD activity with the public health policy guidelines of the sub-district. We would want to understand what the sub-district will see. Probably they think that, okay, academics are doing their own academic work. So we would rather want to get closer to them and say, this is what we found. What are you worried about? Let's work together so that they would support some of this initiative. Strengthen student study abroad program. We would want students to leave the field understanding what they have done and would want to even do more. And the meeting that I held with Thais, Steve, and the group here was to probably enhance the study abroad program. Provide students with more knowledge and skills to be able to disseminate information and to develop more funding opportunities. Somehow in Ghana, our students have started getting funding for the whole student population to be able to go to the field. And we believe that next year the funding would be even bigger. And we would want to encourage that we also set up an initiative to fund the students together so that the students would all be happy to be on the field to help in this initiative. So I try to develop further on some of the things, community as the patient. So we go in and identify the needs of the community and diagnose their problems. Build on strength and resources, identifying more funding, as I said earlier on. Collaborate and equitable partnership. Develop clear institutional responsibilities, for which I think at this current level, what you and University of Utah should do, what SMS should do is clear. We need to then look into the district to make sure that the district also understands its responsibility as we find these public health issues and help us to be able to manage it. Stronger collaboration with the study abroad program, and then realizing that the community impact is also very important. Then we would want to link up, would want to build opinion leaders so that the opinion leaders would rather say, have you checked your BP this morning or this last 6 months? So that they would all be going in and helping us to manage the health needs of the community. My concluding slide is this one. Can somebody guess where this is coming from? MDGs. So these are the MDGs. Are we in MDG, our initiative? And I'll say big yes. When you look at MDG 5, maternal health, we are doing maternal health. MDG 4, we're doing childhood issues there. MDG 7, environmental protection, water and sanitation, we are doing that. MDG 1, eradicate poverty. We believe that if our citrus program works, there's an opportunity to do others in other communities for them to also get some bit of economic power to be able to take care of the community. And MDG 8, I'm here, Utah comes there, global partnership. I think we are doing that. And so what we are doing is almost the MDG goals, and we gradually monitoring our output. And we believe that the findings there would be able to help also replicate somewhere. We try to reward our students as they come to help us on the field work. And so that is myself rewarding a student with a certificate and Steve out there. And the students do a pool party. They dance and do it on the last day, and it's full of fun. There's a swimming pool, and you can see some of the students jumping from level 1, level 2, level 3. Sometimes I'm scared, but Steve says, don't worry, they're experienced divers, so don't no stress, right? And so I would thank you all for finding time to come and listen to me. These are our students and the students of Utah. We're all happy. Thank you very much. Questions, comments are welcome.
What has been the community response to the terrorism efforts and talking to people? Are people pretty excited to talk to them? Are they a little intimidated? Are they confused? Or when you talk to the community after the medicines come talking, what have they thought?
What we do is that for each of the communities we have an opinion leader who is part of the program, and so by the time we get there are community announcements about our coming in, and so they are aware we are coming in. I think for the past 10 years we've been there, and so and they know that for every June, July we will obviously be coming, and so the community acceptance is very high. The literacy rate is high at the rural community. So the process area, we have the tree version, where in some of the communities they can read a tree. And we try to bring more pictures into the flyers such that they can understand the pictures issues rather than reading. And that is what we're going to do. And based on the literacy rate, that is why we wanted them to do the health dissemination in tree. And if they find someone who can speak the English, the University of Utah students also does that in English, and they do it in partnership.
All right, other questions? Daniel? Oh.
I think for the audience, I don't know if Stephen touched on it, but can you describe kind of what the health insurance policies are as far as people who can use medication for their high blood pressure? So when you find their blood pressure, what is already in place to help them get care?
Yeah, so that is right. Once you identify to have hypertension and you have your national health insurance card, and the coverage is very wide even within the rural communities, and you have free antihypertensives. So the issue is to identify them, counsel them, and them to have the antihypertensive. It's not a cost issue. It's a bit of a knowledge.
Daniel, wonderful presentation. One of the things that's always concerning in that is you said everybody has bed minutes. Are these supplied from outside, or are there local people that are able to generate their own income and have an economy? Or are we destroying the economy of the local population by flooding the field with all these nets and not allowing them to make them themselves? Is that a problem or not?
Yeah, the nets are not making that Ghana. What I know is that as part of the MDG 4, childhood mortality reduction, I think Ghana assessed bed nets for every community or every caregiver with a child less than 2 years in the household. And so it was given widely distributed, and it's being monitored. And so I think some funding is coming from the Global Fund in Sub-Saharan Africa to do that. And it came at the right time too. Ready, one.
Seems to be a problem. Is there an easy way to help them with that?
I would say yes. Our health information program that we're going to strengthen is going to ensure compliance as well as educate them to take their medications. And we, I think, should develop the scheme such that we're able to measure how many of these community people access cheap compound for hypertension, as well as those who go to the district for refill of their hypertensive drugs. And there's a responsibility there, identifying them, offering them the medication, monitoring and making sure they're complying to the medication is also another challenge that we would need to look at. But what I know is that in a Ghanaian who has a disease that has been identified and he knows he's on this medication, he's receiving medicine, they would want to take their medications. Okay.
All right. Thank you, Daniel.